Good afternoon, everyone. I am Ada from IJCP. Welcome all our participants for today's insightful CME. I warmly welcome you all for today's CME session. It gives me great pleasure to introduce our topic of discussion. The topic is the unusual suspect tracking down the cause of thyroid enlargement. Thyroid disorders are among the most common endocrine conditions we encounter in clinical practice. And while many causes are familiar, there are times when the underlying reason is less obvious and demands deeper exploration. Today's session will help us gain insights into identifying and managing such unusual presentations. We are honored to have with us Professor Dr. Ganesh HK. Sir is a highly respected name in the field of endocrinology. He is the professor and head of the Department of Endocrinology at AJ Institute of Medical Sciences, Mangalore, and also serves a consultant endocrinologist at the Mangalore Indodiap Clinic. With his vast clinical expertise and academic contribution, he has been a guiding force in advancing thyroid and endocrine care. Without further delay, I would like to hand over the session to you, sir.
Good evening. Good evening. Uh, at the outset, I would like to thank IJCP for giving the opportunity. For the next 20 to 30 minutes, we'll discuss regarding an unusual cause of thyroid enlargement. So, usually, we encountered thyroid enlargement every day in our daily practice, be it an endocrinologist, physician, surgeon, ENT surgeon, general practitioner. We see a lot of thyroid enlargements, different types of thyroid enlargements. This is a little unusual from what we say, what we see in day-to-day life. So let me start the case directly. The 68-year-old gentleman presented with the dyspnea since the last 15 days, and he had difficulty in breathing in the form of stridors in the last 3 days also. And so last 15 days, when we asked, he was complaining the history of hoarseness of voice. So the dyspnea since 15 days, stridor since 3 days, and hoarseness since 15 days. So the dyspnea was gradually increasing, and there was no orthopnea or paroxysmal nocturnal dyspnea. And he had the increasing stridors in the last 3 days, and the dyspnea was not improving on treatment from the local nearby nebulization. All everything was tried, but that was not improving. He also complained of hoarseness of voice in the last 15 days, which was also increasing gradually. And there was no improvement with the voice rest, or there was no history of fatigue or fatigability of voice with the use, and there was no change in diurnal variation of voice. No history of gastroesophageal reflux or sinonasal disease. Symptoms suggestive of all the reflux and sinonasal disease was not there. So on examination, so when we examined him, so he was a well-built gentleman. Pulse was 66 beat per minute. Weight was 72 kgs. Saturation was well maintained, 99% on room air. Blood pressure was on the lower side, 100 by 60 millimeter mercury. There was slight increase in the respiratory rate, 32 per minute. Temperature 98.6. There was stridor. We could actually hear the sound, grunting sound while he was breathing. His systemic examination was normal. There was no general physical examination clues also, other than this goiter, which was visible and palpable also. On examination, there was a grade 3 goiter. So he was, since the stride was disturbing him, so there was increased respiratory rate, tachypnea was there. So we started him on IV steroids, hydrocortisone 100 mg IV stat was given, and when we took the history, past history, there was no history of thyroid surgery or neck surgery, no history of perioral numbness or carpopedal spasm, which is suggestive of hypocalcemia. Hypocalcemia can present with stridor. That's the reason all these questions were asked. No history of foreign body aspiration, and no history of trauma in the past or endotracheal intubation in the past, which can give rise to all this difficulty in hoarseness of voice and difficulty in breathing, all these things which can happen because of these things, but it was not there. Significant past history was there in the press in terms of coronary artery disease, and he underwent angioplasty 12 years back, and he had a history of fracture in the left lower limb following road traffic accident, which happened 3 years back. Other than that, there was no significant past history. He was on aspirin 75 milligram per day, atorvastatin 20 milligram per day, and clopidogrel 75 milligram. On enquiry, he told that he started noticing this neck enlargements in the last 2 months. This neck swelling, he didn't give much notice and didn't give much attention to that, but still, he thought it's increased in the last 2 weeks. Last 2 months it was there, but since the last 2 weeks it significantly increased in size. There was no pain. History of fever and sore throat was there, which was 1 month back. So he was evaluated elsewhere for this swelling. Actually, outside some hospital, it was evaluated at that time. So he was not very much bothered, but his children took him there. So he presented to our emergency department because he had developed stridor in the last 3 days. So when he was evaluated in another hospital, so his investigations were like this. He had a neck swelling. So the TSH was 16.57. We can see here. FT4 was on the lower side of normal. So it was diagnosed as a primary hypothyroidism with the multinodular goiter. Since the TSH was 16.57, he was started on thyroxine 50 microgram per day. So chest X-ray was normal, and even the spirometry was done since he was complaining of some difficulty in breathing. So, but it was fine. USG neck was suggestive of thyroid gland, which was diffusely enlarged in size. It was not looking like a multinodular goiter in USG. So probably the multiple lobulations were there. So that is the reason it was looking like diffusely enlarged. It was completely replaced by ICO2 hypoechoic nodules. So diffusely enlarged, but replaced. So multiple ICO2 hypoechoic nodules, but diffusely enlarged gland. The TIRAD scoring was coming to 4. So largest nodule on the right side was 1.5 into 2.5 centimeter. Left side it was 1.2 into 2.1 centimeter, and there was no evidence of lymphadenopathy. Then the CT neck was performed to see the extent of this enlargement. There was a large pretracheal lesion with altered morphology of thyroid with minimal substernal extension, probably thyroid in origin. So they suspected query it is neoplastic. So that is the reason FNAC was done in February 2024 before he came to our hospital outside another hospital. FNAC was suggestive of subacute granulomatous thyroiditis with some amount of atypia. That's why they give it as Bethesda category 3. Otherwise, usually granulomatous thyroiditis will not be categorized into Bethesda 3. But since there was some amount of atypia, the report was given as Bethesda category 3. So summarizing the history till now, history and examination part, 68-year-old male, history of angioplasty in 2012, presented with neck swelling since the last 2 months with rapid progression of compressive symptoms since the last 15 days in the form of dyspnea and stridor, with background history of fever and sore throat, and FNAC showing subacute granulomatous thyroiditis in the outside hospital. So these were the differential diagnosis. Subacute granulomatous thyroiditis. Subacute granulomatous thyroiditis, the positive findings here, which is in favor of subacute thyroiditis, is the pain and history of fever and sore throat in the recent past, and FNAC showing granulomatous lesions. Otherwise, the rapid increase in size, sudden increase in size with the stridor, breathing difficulty, all this does not go in favor of subacute thyroiditis. That's why the differential diagnosis, other differential diagnoses are the rapidly enlarging thyroid enlargement with stridor, anaplastic carcinoma, and thyroid lymphoma. These are the things to be considered. Riddle's thyroiditis, which is a little very unusual because it will be very fibrosing disease and it will not be, the FNAC will not be showing the granulomatous lesions. So these are the differential diagnoses that we kept at that time. So the blood investigations we did in our hospital showed the hemoglobin normal 11.8 on the lower side of normal, we can say. The CRP was high 31.5, suggesting that there is some inflammatory changes going on, and ESR was also high, either inflammatory or neoplastic lesion. It was suggesting. Kidney function normal. Electrolytes were also normal. The calcium was on the lower side 8.1, phosphorus was 3.1. ECG was showing normal sinus rhythm. Echocardiogram, ejection fraction 50%. Adequate LV systolic function was there. So at that time, he was managed with injection of hydrocortisone, 100 milligram thrice daily. Since the TSH was elevated, 17 in the last visit, 1.5 months back in another hospital, so he was put on thyroxine, which we continued. But so even after 2 days, there was no improvement in Strider. So his discomfort was increasing. He was also complaining of fever and night sweats. He was totally uncomfortable. We repeated the CT neck with contrast. We showed diffusely enlarged thyroid gland. We can see here in the middle of this one, you can see the diffusely enlarged thyroid gland compressing the trachea. You can see the narrowing of the trachea here. You can see this air sign here. This is a trachea, lumen very much narrowed. That is the reason for Strider. There was a retrotional extension also. Calcific lymph nodes and amorphous calcifications were seen in bilateral thyroid lobes, which were suggestive of neoplastic etiology. So the suspicion of neoplasm increased actually because subacute thyroiditis presentation like this is extremely uncommon. So because usually they will not present with this Strider, and this much of enlargement with retrotional extension and calcific lymph nodes, all these do not go in favor of subacute thyroiditis. So there it was suggestive of neoplastic etiology only. So we can see here. So diffuse narrow. So here the enlargement of the gland and compression of the trachea. So probably you can see the trachea is narrowed this much. This is the reason why the patient was going into Strider. The core biopsy, we did the ultrasound guided core biopsy. We can see here the lymphoid aggregates. So there were lymphoid aggregates. So once again, suggesting Hashimoto's thyroiditis. So we can see here the lymphoid aggregates here, multiple linear thyroid biopsy cores with dense lymphoid proliferation at places forming lymphoid aggregates. These lymphocytes are small sized with mildly pleomorphic hyperchromatic nuclei. So fibrocollagenous connective tissue was also there, and infiltration into the attached skeletal muscle bundles also noted. So the conclusion given from the core biopsy was atypical lymphoid proliferation in a background of Hashimoto's thyroiditis. This was the core biopsy impression. Atypical lymphoid proliferation in the background of Hashimoto's thyroiditis. They also suggested immunohistochemistry to rule out lymphoma. So we were planning for that immunohistochemistry, but the condition was worsening. The way he was not at all happy. So the Strider was worsening. So we couldn't wait for that. So that is the reason the oncosurgery opinion was sought, and the decision was made to go ahead with thyroidectomy. So tracheostomy was done, and the surgery was restricted to only right hemithyroidectomy because oncosurgeon he couldn't completely resect the gland. There was dense adhesions and fibrosis. So our oncosurgeon felt if he tries to remove the whole gland, he will end up in damaging the recurrent laryngeal nerve as well as the parathyroids will be removed. So that is the reason he restricted his surgery to right hemithyroidectomy. The post-operative period was uneventful. Calcium was transiently low and correction was done. So then the immunohistochemistry from the came. So it showed atypical lymphoid cells expressing CD20, CD10, and BCL6. CD20 positive cells you can see here. And Ki67 proliferation index was very high, 70%. So the diagnosis was morphology as well as immunohistochemistry support the diagnosis of diffuse large B-cell lymphoma, germinal center type. So it was a case of diffuse large B-cell lymphoma involving thyroid in the background of Hashimoto's thyroiditis. So the oncology reference was given. B symptoms like fever and night sweats, which he was complaining prior to surgery only, which was persistent even after the surgery. CT scan of the whole abdomen was done to find out any lymphoma deposits are there in the inside the abdomen also. As a part of workup, we did LDH, which was 257, and beta 2 microglobulin 1.9. So he was started on chemotherapy. R-CHOP regimen was given. So he was discharged on 26th of March with the tracheostomy tube in situ. Slowly later, the tracheostomy tube was removed, and rituximab, cyclophosphamide, doxorubicin, prednisolone, and vincristine. These were the chemotherapeutic agents given in this CHOP regimen, R-CHOP regimen. Finally, he was discharged from our endocrine side with the 75 micrograms of thyroxine, calcium citrate, and roquetrol, that is active vitamin D. So that's how the story unfolded, and he's doing well now after the chemotherapy. He is doing very well. The contrast enhanced FDG whole body PET CT was done. It was showing sub-centimeter size non-FDG avid hypodense lesion noted in the left lobe of thyroid. Otherwise, no evidence of metabolically active disease elsewhere in the body. You can see the FDG PET scan here, film. He's on follow-up. 5 cycles of chemotherapy completed, and after that, roquetrol was stopped, and he's only on calcium citrate. Overall, he's doing very well, only on thyroxine, 75 microgram per day. Coming to some of the basic details regarding primary thyroid lymphomas, which are not very common. It's a rare malignancy, accounting for approximately 0.6 to 5% of all thyroid malignancies and 2.5 to 7% of all extranodal lymphomas. They are more common in women with a 3:1 female to male ratio. Hashimoto's thyroiditis or chronic lymphocytic thyroiditis present in approximately 60% of the cases, which increase the risk of thyroid lymphoma by approximately 60-fold. They present in the usually 6th or 7th decade of life, with mean age of presentation between 64 and 65.8 years. So it's not a common malignancy compared to other thyroid malignancies like papillary carcinoma thyroid or follicular carcinoma thyroid. They are very uncommon. Only 5%, maximum 5% of all among the all thyroid malignancies. They usually present with rapidly enlarging painless neck mass in almost all cases. So beware of a mass which is rapidly enlarging in size. You might be treating the patient as primary hypothyroidism all this while. Suddenly, if the patient complains of sudden increase in size in the last few weeks or months, then you have to be a little cautious. Probably you are handling a patient of lymphoma. Usually, the hoarseness, dysphagia, dyspnea, all can be there in around 30% of the lymphomas, and 10%, less than 10% of the patients can have compression of the superior vena cava and symptoms related to that. B symptoms like fever, night sweats, weight loss occur only in 10%. Diagnosis is usually made by FNA. FNA with the immunohistochemistry. FNA, there is just like in our patient core biopsy. Whenever there is doubt, we have to do immunohistochemistry. Surgery is not required in most of the patients, but when situations like this, when the patient is having rapidly increasing in size of the gland and patient having difficulty in breathing stridor, probably it may be required in few cases, selected cases, but in general, surgery is not required for thyroid lymphomas. Core biopsy is the ideal procedure for establishing a definitive diagnosis with immunohistochemistry. Clinical staging is done using the Ann Arbor classification. So this staging requires LDH, beta 2 microglobulin, serum protein electrophoresis, neck ultrasound, and CT scan. On 18F, this FDG PET scan, thyroid lymphoma has a higher SUV max and lower CT density than chronic thyroiditis. That's how we can differentiate the chronic thyroiditis from thyroid lymphoma. We can do FDG PET scan. In that PET CT, FDG PET will be showing higher SUV max with the lymphomas, but CT density will be lower compared to chronic thyroiditis. Most thyroid lymphomas are non-Hodgkin's lymphoma type of B cell origin. The most common subtype of primary thyroid lymphoma is diffuse large B cell lymphoma, accounting for more than 60% of cases, followed by marked lymphoma, that is mucosa-associated lymphoid tissue lymphoma, which is approximately 10 to 20%. Rarer subtypes like follicular 10%, small lymphocytic lymphomas 3%, Hodgkin's lymphoma 2%, and other subtypes, but Burkitt's lymphoma, T cell lymphoma, mantle cell, and lymphoblastic lymphomas. All these account for less than 1%. So it's mainly diffuse large B cell lymphoma of non-Hodgkin's type, followed by malt lymphomas. These are the common types. So, what are the differences? Diffuse large B cell lymphoma, more than 50% of the cases, it is diffuse large B cell lymphoma. Malt lymphoma is less common. Diffuse large B cell lymphoma is more aggressive compared to malt lymphoma. And cytology wise, there will be large monotonous lymphoid cells, lymphepithelial lesions, decrease or absent colloid in a diffuse large B cell, and malt lymphoma, intermediate site cells, lymphepithelial cells, reactive lymphoid follicles, and plasma cell component. Treatment wise, diffuse large B cell lymphoma, since they are aggressive, they usually require radiation plus chemotherapy, whereas mild lymphomas, localized radiation is enough. Most of the times it is localized, so that's why radiation therapy is enough. 5-year disease survival rates, 71 to 75% in diffuse large B cell lymphoma, whereas in mild lymphoma it is 96 to 100%. So already discussed the regional therapy, external beam radiation therapy is useful in mild lymphomas, and advanced stages and diffuse large B cell lymphomas usually require chemotherapy. Most common regimen is R-CHOP as already discussed. So this includes cyclophosphamide, doxorubicin, vincristine, prednisolone, and rituximab. So concluding today's case, rapid enlargement of thyroid gland, whenever it is there, suspect lymphoma or anaplastic carcinoma. Don't conclude that the patient is having that, but you have to keep your eye open to keep lymphoma or anaplastic carcinoma in mind. Core biopsy is helpful in majority of the patients. Core biopsy with immunohistochemistry will tell us the diagnosis. Surgery is not required. In rare situations, exceptional situations, surgery may be needed, but it is not the general rule. Diffuse large B cell lymphoma are more common and more aggressive. Radiotherapy and chemotherapy are the treatment modalities of choice. Thank you. So I would like to acknowledge Dr. Y.N. Krishna Reddy, our senior resident, who has helped me to prepare the slides. Thank you. So you are muted, Ada. Yeah.
Thank you for the answer, sir. I hope you did justice with this topic, sir. Now
Thank
moving
you.
to the most interactive part of the session, sir, the Q&A session. Like we have received some great questions from the audience. Let me begin with the first one. The question is, how do you find needle aspiration, cytology, FNAC, and core biopsy contribute to narrowing the down the cause?
Okay, so the FNAC, fine needle aspiration cytology, is helpful in many patients if the clear-cut diagnosis is there. If it is fitting to the clinical picture, then we can use. Always, it's better to go for ultrasound-guided fine needle aspiration cytology. Core biopsy, which involves a little, the material taken is much larger, much better. That's why if it can be done, core biopsy, ultrasound guided core biopsy is much better compared to fine needle aspiration cytology. If there is dense lymphocytic aggregation, lymphoid infiltrates, then you have to suspect thyroid lymphoma, but it is quite uncommon. So when we are in doubt, probably from the core biopsy specimen, immunohistochemistry we have to do. Both FNAC and core biopsy have a role in the management of thyroid enlargement. Whenever in an ultrasound, if the thyroid score is more than 3, we have to do FNA to rule out a chance of malignancy. So if the thyroid 3 nodule is there, if the size is more than 2.5 centimeter, it's better to do an FNA. So if the 2.5 centimeter less than the size and thyroid lesion less than 3, 1 or 2 and 3 less than 2.5 centimeter, FNAC may not be required. Yeah. Any other question?
Okay, sir. Yeah. Thank you for the answer, sir. And I can see there is another question. The question is, when is cross-sectional imaging, CT, MRI indicated in thyroid enlargement, sir?
It's a very good question actually. So the ultrasound is the best modality for a diagnosis and a prognostication of thyroid enlargement. Ultrasound is the best modality. CT scan is required only to know the extent of the thyroid gland, the goiter size. So if there is a doubt, there is a substernal or retrosternal extension, or if there is how much tracheal compression is there to make that, so we can do CT scan. And one more is when we are suspecting when the FNAC has come as papillary thyroid carcinoma or follicular thyroid carcinoma, whether there are any other lymph node metastasis is there. So to decide on the thyroidectomy, how radical they should go, how much radical lymph node dissection the surgeon has to do. For that, CT scan is required. So we can note down 3 points actually. One, to assess the retrosternal extension. Second, to assess the tracheal compression of the goiter. Third, to stage the disease, to know the extent of thyroidectomy. So these are the three indications for CT or CT neck, CT scan of the neck. Yeah.
Okay. Thank you for the answer, sir. And I can see there is a last question. The question is, how do you assess compressive symptoms, stridor, hormesis, clinically and radiologically?
Clinically, if the patient presents with stridor, the grunting sound, whatever was there with our patient, it suggests that there is some compression. Then the stridor may not be obvious. It may be obvious only when the patient is sleeping in the lying down position, supine position. The spouse may complain that in one particular position the sound is more. Then that is also suggestive of a compressive symptom. One more is Pemberton sign, so in which the patient is made to lift the hand above the shoulder, touching the ear for at least a few minutes, 2 to 3 minutes. And if there is swelling of the face or facial flushing, that suggests that there is compression of the superior thoracic inlet. So suggesting that there is some compression, superior vena cava syndrome kind of thing, Pemberton sign. Then radiologically, obviously the CT scan will tell us whether there is compression.
Sir, with all your permission, and thank you for the answer, sir. And with all your permission, sir, can I conclude the session?
Yeah, thank you.
Okay, and thank you, audience, for your questions. And thank you once again, sir. Sir, I'm going to like end it.
Thank
Thank
you.
you, sir.